Jong-jin. Kính thưa quý vị, Thạc sĩ bác sĩ Kim Yong-jin tốt nghiệp tại Đại học Đan Quốc, Hàn Quốc. Bác sĩ được chứng nhận bởi Hội đồng Phẫu thuật răng hàm mặt Hàn Quốc và Hội đồng Phẫu thuật và Tạo hình hàm mặt Hàn Quốc. Now, ladies and gentlemen, please welcome Dr. Kim Yong-jin. Good afternoon, Dr. Kim Yong-jin. Thank you for visiting Da Nang. Could you introduce the topic of the first session to the audience? Thank you.
Very good afternoon. So I'm Dr. Yong-jin Kim from Korea. I'm very happy to be here as a moderator, and also I'm very honored to have opportunity to introduce my favorite dentist, Dr. David. He is so passionate in lecturing, so you must be happy after listening his lecture. So to introduce Dr. David, he has graduated New York University College of Dentistry. He is diplomated American Board of Oral Implantology, and he is a founder and director of Think Dental Implant Institute and Study Club in New York. So now he is a director of Think Dental Clinic in New York. So let me give you Dr. David.
Xin chào, tôi tên là David Chung. Hi, I'm going to talk about a management of complication in transcrestal sinus lift procedure for a dental implant today. First, I'd like to thank this wonderful city of Da Nang. I was very, very surprised how beautiful the city was in the morning, and I'm sure it's more beautiful as the time goes along. I also thank my moderator, Dr. Yong-jin Kim, who's going to be a following lecturer. You must hear him because he's an excellent lecturer, and I'm going to introduce him a little bit later. I also thank Austin, Vietnam, for giving me this wonderful opportunity to present in this enthusiastic crowd in Da Nang. So, I'm going to start by thanking my mentors and friends for this presentation, including Dr. Yong-jin Kim. And now my sinus complication management divided into a fourth section. Consideration for transcrestal sinus flow elevation, complication and discussion on transcrestal sinus augmentation, and transcrestal sinus lift cases with additional preventive strategies. So let's go with considerations. Now, indication for sinus surgery is quite a lot in posterior maxilla, because their anatomical limitation with pneumatization and alveolar resorption, they might require additional surgery. And it is often require additional surgery such as this to make a augmentation so that you can place implant at the ideal position. Now, there's two different approach to to get into the sinus that augment the bone. First, usually it's a lateral approach. It's a little bit more surgically involved, whereas the transcrestal approach could be a more minimized approach. But you must understand, this is just an approach, but what's happening inside the sinus is exactly identical. So you must understand the physiology, biology, and also biomechanics inside the sinus before you even do a procedure. So now, you can see a disadvantage of the lateral window osteotomy due to anastomosis vessels right there. And during a osteotomy, during the lateral window, you could damage and you could rupture the vessel such as that. Unfortunately, we cannot all detect in a CBCT sometimes, but it doesn't mean that a vessel does not present. So, you must try to locate the vessel and make the window underneath it. But many times, it's inherent a perforation could occur. This type of trauma needs to be controlled, and certainly it's not going to be controlled with a DSO only. Every time time heart pumps, then an artery pumps as well. So it depends on the thickness of the vessel if decides to diffuse bleeding versus a minor bleeding. But I feel that there's no such thing as a minor bleeding. There is a bleeding and needs to be controlled, especially an arterial bleeding, of course with the pressure. But now, I feel that there are three or more sinus consideration, and I listed four of them. So we're going to talk about a residual alveolar bone height, which is general thinking. We used to think that a 6 millimeter was the key to a success and predictability for a crestal sinus lift, whereas it goes down as we study more and more cases has been introduced in international journals, and right now, it might be about 4 millimeter or greater that you might want to try a crestal lift to gain that predictability that we want. But it's not just the residual alveolar bone height. We need to think three-dimensional. Our human being is not like a paper, it's not flat, it's three-dimensional. So sinus width at the proposed apex at the planned implant might be the key to measuring the width. So as you see, this is not a post-op picture, this is a pre-op picture, which you could see. You can measure the width from the apex. And if you have a less than 12 to 13 millimeter, we consider that as a narrow sinus. When we have a greater than 12 to 13 millimeter, it's considered a wide sinuses. And there are a huge difference between a narrow sinus and wide sinus in terms of a predictability, especially in crestal approach. Now, increasing a width can be a risk in crestal approach. You might not get a full coverage of the bone, as well as you might need to wait longer for a vital bone formation for you to load any occlusal load. Now, as you see the study by Dr. Hoyo Jang, he studied a narrow sinus versus a wide sinus in terms of a medial wall moment. Medial wall is where lots of blood supply and cell signals are being sent to the fat material to make sure that fat material will turn into a human bone or maybe into a nice complex of the bone augmentation. But now, in narrow sinuses, you're more likely to get involved with the medial wall, whereas in wide sinuses, it might not be as predictable as narrow sinus. As such, as you can see, the convexity in yellow line shows you that a containment of the graft material, but concavity up there is really showing you there was a perforation. When there's perforation, you must check the shape after post-op and post-op CBCT, because if you see a convexity, that means the graft materials are nicely contained. But when you see a concavity up there, that means that something has escaped. As the Schneiderian membrane gets separated, you get spontaneous bleeding from the capillary. And those capillary bleeding will leak out above the Schneiderian membrane to cause an adhesion with the sinus wall. Adhesion looks like a concavity. So you expect this patient to have a nose bleeding or maybe some type of discomfort and a possible sinus infection, but usually not. So in this case, I feel that sinus lifting is well done, but there was a perforation. And you could get a more perforation in wide sinuses, and we're going to talk about it more and more. Dr. Spinato's research right here will show you that he placed the crestal lifts, he placed the implant with the crestal sinus lift in narrow sinus and wide sinuses. And you can see that a more bony coverage in a narrow sinus than wide sinus, especially when you have a very little residual alveolar bone height. Now, not just the sinus width that's important and the length that's important, broad detachment of the Schneiderian membrane is very, very crucial. Broad detachment is very easily detected in a lateral sinus lift. Why? Because you could directly see it. A crestal sinus lift is a lot of guessing game. You must check each step to make sure that you're getting a broad detachment to increase the predictability of the augmentation process. But as you can see in medial wall, you can see a sphenopalatine artery and greater palatine artery is both supplying to the medial wall, that I feel that this might be the reason that being medial wall, getting medial wall movement is a very crucial process for a successful sinus bone augmentation. Now, broad detachment in lateral and a crestal should really be the same way. Unfortunately, we don't have much control in crestal. So we need to find out which process will really will lift the membrane broadly. Is it just the osteotome? Is it hydraulic pressure? Is it hydrodynamics? We're going to talk about that. And as a broad detachment of the stridarium membrane to expose the medial wall, now we have a greater chance to have a good bone augmentation. As you can see, this picture looks same in PA when you take it from here, just the same in PA. But when you look at it in a CBCT, you can tell a tremendous difference. Bone formation starts from the sinus wall and actually travel. It needs to travel quite a bit with a less of the signal. Whereas you can see all the signal from other direction will make this much easier. So, this is wonderful biology to lift the stridarium membrane widely and broadly. But it's not just the biology. I feel that it's also biomechanic. Now, you can see the red line. This is how much a membrane is going to be a stent on the top of the implant. And when you see a yellow line right there, you can see how much stridarium membrane is being lifted. When you see a yellow line is longer than the red line, that means a red line is not getting too much tension. So you have a less chance of the perforation in biomechanic in my personal mind. As you can see a yellow line is shorter than the red line. Now the red line is getting less of tension, which I feel that increases the chance of the perforation. So it's not just biological, but as biomechanical as well. Now finally, but most importantly in my personal thought, is sinus health. It doesn't matter what you could do. You could be the #1 surgeon in the world, #1 sinus surgeon in the world, but unfortunately, when patient's sinus is not healthy, you're going to increase the risk of causing some complication, including infection or others. So now, health of the sinus and predetermining the health of the sinus is going to be the key for sinus lifting. So you must know what's normal and what's not normal. Normal happens to be around 2 millimeters or less of the stridarium membrane thickness was considered normal in many different studies. But I really feel that, and Dr. Camelli feels that, the pattern of a stridarium membrane is very, very crucial of determining whether sinus is going to be obstructed or maybe it's not going to be obstructed. So when you see this 5 different patterns, what do you think? The 3 pattern right here, irregular, circumferential, and complete pattern, has a greater chance, much greater chance for the sinus to be obstructed. Sinus is communicated through something called ostium, which is 2.4 millimeter opening. When a ostium gets compromised, then you're going to get stagnant sinus. It's now more drainage, stagnant, which could cause acute sinusitis, and eventually, if that's not getting treated, it's going to lead to chronic sinusitis. You need to also look at extraoral exam. It's not just an intraoral that counts. You guys are not technicians, you guys are physicians. So, you need to take a look at everything, every factor, which includes an extraoral exam. When a patient has a trauma to the nose, any type of trauma to the nose previously, then patient has a chance to get some type of compromised ostium. When patient has compromised ostium, not many good things could happen. So, you must check for an extraoral exam as well. So, my major goal when performing a sinus augmentation is not to try to perforate the sinus membrane, of course, and supply a more bone-forming cell by a broad detachment of the stridarium membrane from the wall. Now, there are many different methods. I have tried many different methods to lift the sinus. Which one is best for me? No, the question is, which one is the most predictable for me? I really feel that a crestal approach using hydraulic pressure is the most predictable method for me. Why? Let's apply the physics principle, Pascal's principle. So when you see the stridarium membrane being lifted with the hydraulic pressure, that means that all the medium underneath that membrane is achieving same amount of force, equal force, lift, equal force, so that a membrane will not be traumatized or minimally traumatized if there is a trauma. It's applying a physics principle called Pascal's principle. Safe and predictable elevation of the sinus membrane, and also I feel that a broad detachment can be possible. Now, also, there's a septum, there's a lot of irregularity, and there's a root eminence called HELOC. And during a lateral augmentation where you need to separate the schneiderian membrane with the mechanical instrument, it's very, very hard to overcome all these irregularities. Of course, the septum as well. Septum can be very sharp, and you see a schneiderian membrane, tensed schneiderian membrane is covering the septum. And when you touch that septum, schneiderian membrane will open up. So it's very, very dangerous to approach a mechanical instrument unless you're very proficient in lateral sinus lift. So septum is present in a 30%, about a 1/3 of a patient, which is premolar region. So it's a very, very common thing to have. But now, using a hydraulic pressure, this is the frontal sinus of the pig. Using hydraulic pressure, if you could overcome the complexity of the frontal sinus, I think that you could really overcome a septum without a problem. Rise. Without any risk of membrane perforation. Now, this is my mentor, Young-Suk Cho, and when he was doing a live surgery, there was endoscopy, or sinoscopy, was inserted inside the sinus to visualize what's really going on in live time. Now, as you can see, hydraulic pressure is being inserted. And this is the septum, and there's a cyst. Well, cyst is already small. Can we ignore that? Do we need to always remove the cyst? Absolutely not. Using hydraulic pressure, you could overcome the irregularity as well as some type of a mass on the top. And when it's a separated widely, you just need to put some type of space maintenance, such as bone graft material, to make sure that you occupy the space without risking any of the membrane perforation. Look at that, rise. So now, once you actually lifted a sinus, the schneiderian membrane has lost the tension already. When it loses tension, it's hard to damage any structure when there is no tension. So, a perforation could occur at any stage, including a grafting or an implant insertion. But now, when you see this, you can see a really tensionless grafting and literally tensionless insertion to minimize any type of perforation. If you loosen the tension, you minimize any type of perforation. You're constantly fighting with tension. Tension, tension. When you do a guided bone regeneration, you need to lose the tension of the flap. When you do sinus lift, you need to lose the tension of the schneiderian membrane. So, how does that go? This is a very easy case with wide ridge. So you make an initial osteotomy. Okay. Sound. Okay, and then you need to constantly make it wider and a millimeter by millimeter you're going to approach. Make sure that either to check you're in or not inside the sinus. And now, hydraulic pressure. Okay, not bad. And when you see blood, because of a spontaneous capillary breakage, could cause the bleeding, and this bleeding is being sucked with the tube. And now, completion of the access to the sinus cavity, and now, grafting. So now try to take out all the fluid by getting rid of that space and also check for a membrane, a perforation, and now insertion of the implant. And check the ISQ value after you achieve a best of the coronal position. It's 83 over 81. Excellent position stability. So we're going to put a healing abutment and suture to make it a one-stage surgery. So now this is the result of the inclined sinus without much of the effort. And I feel that because of the hydraulic pressure, it really made my sinus lifting very easy. So now I'm showing you what I do, but I want to show you how to manage the complication. From a complication, if you do not know how to manage, then it leads to failure. From a complication, if you know how to manage, it becomes recovery. So we want to recover, not fail. So we must know the complication before we start the procedure. And management, of course. Now, incidence. This implant fixture could be inside the sinus, and now what are you going to do? Well, there are many contributing risk factors for this. Now, should you remove the fixture? Most of them are asymptomatic. Should you remove the fixture? And certainly, we advise you to remove the fixture because there's indication that you could get a cluster headaches, chronic sinusitis, fungal infection, including aspergillosis, and adverse tissue reaction, including neoplastic changes. Certainly, we don't want that to happen. So removal is recommended, and because it can be problematic. But when to remove? When do you remove that? My recommendation, and many people's recommendation, is to remove as soon as possible. Why do you want to remove as soon as possible? Because it gets stuck to all the soft tissue, it gets encapsulated, and it's very, very hard to remove if you wait. Also, how would you remove it? There are a couple of methods to remove it. I saw recently that you could, when implant goes into the sinus, you could blow the nose a little bit. You could go, huh, 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 like that, almost like a Valsalva, and try to let the implant go down so that you could retrieve it. But in reality, I like a lateral window approach. Lateral window approach, if that does not work, I feel that a lateral window approach is the most predictable. If you don't feel good with the lateral window approach, when patient gets referred to the ENT, they might be taking it out to the nose with a functional endoscopic surgery. So remove the fixture as soon as possible because it will be fixed into sinus membrane if you wait too long. Now, how do you remove that? And you could use the high suction power tip or even an ENT forceps to remove like this. So check the location before the surgery and a radiography and check it with the curette and try to find that a rough surface and then remove that as soon as possible. But now, in order to remove that, you need to cut the Schneiderian membrane. Implant is beyond the Schneiderian membrane. So you need to cut the Schneiderian membrane to achieve it most of the times. But where would you cut it? Where would you cut it? Well, I feel that if you cut it right at the top, it is the easiest to achieve. If you go near the anterior wall, it becomes very, very difficult. So, if you're going to make an incision at the top of the window and top of the Schneiderian membrane so that you could retrieve that implant fixture, as well as you could fix it. You could fix the membrane, and maybe you could do it in one stage. You could do it that same day. You could do a sinus lifting same day. And certainly, Julian An, which is Dr. Onigen also, they suggested that you remove the same day to reduce the patient's frequency of the visit, plus they reduce the chance of more complication by making a window on the top and using the resorbable membrane to make the sealing. I feel that, I use the same technique, but you could actually put the pin on the medial wall to create a sealing and do the sinus grafting like usual. Or you could make a hole. If your trigeminal membrane is thick enough, you can make a hole on the bone on the top and then suture them together to seal that preparation and make sure that you seal the preparation nicely and then put the bone graft material, and you could even put an implant if you wish to. So now, prevention is the best way, we know that. So how do you prevent this type? The initial stability of the implant is the most important factor. If you don't have a good initial stability, especially if you put a healing abutment to make it into a non-submerged, then you have a higher chance to have some type of problem. Also, sufficient healing period is needed. If you don't wait a sufficient time, maybe bone graft material is still being processed into the bone, patient's own bone, then you might have a problem that an implant will shoot right into the sinus after you load. And also, this is the most, I think that this is the biggest factor. Don't try to force the crestal approach in a residual bone height less than 4 millimeters. I'm going to show you some examples that you can. But in general rule, if you have a very little residual bone height, it is risky to do a crestal approach in many different aspects. So, lateral windows approach in those cases. Now, what about maxillary sinusitis? Let's go with the second complication of management. What about an infection? Is it dental origin? Is it odontogenic? If it's dental origin, you could probably treat the dentition and stop from a migraine, right? Or stop from disease from migraine inside the sinus. So, medication and dental treatment, if you relate it to get rid of the etiology of the problem, might be the solution. But if it's not a dental origin, you can take a medication, or if you cannot handle it, refer to an ENT doctor. Now, I believe in a pre-op. I don't like post-op too much. I like pre-op. Pre-operatory really minimizes the post-op complication, in my personal opinion. So, begin dosing 24 hours prior to surgery, 7 days after. Now, for sinus augmentation pre-op, when patient is not allergic to a penicillin, I like to prescribe a augmented 875 milligram BID twice a day, and this is a protocol from Dr. Testori in the Testori's journal in 2012. When patient has an allergy, then you need to change your medication. I don't like to use a clindamycin, and according to the journal, clarithromycin combination with metronidazole is going to be a better medication for the pre-op or allergic to a penicillin patient. So what about even though you did everything, patient developed a sinusitis? What would you do? Usually a post-op infection is mixed with 2-to-1 anaerobes. But now, if you see a cloudiness and symptom, patient's eyeball hurts, and a lot of pressure around the sinus area and a lower orbit area, then you first want to prescribe an antibiotic, but you need to prescribe it strongly. 875 TID, that's 3 times a day for 10 to 14 days. And also combination with metronidazole, 500 milligram, 3 times a day. But now, I got the tip from my mentor, Dr. Yongjin Kim, and he said, Banon, which is 3rd generation of the cephalosporin, happens to be a very, very good drug of choice. So I hope that my patient do not have sinusitis, but if my patient does come up with sinusitis, I'm willing to try Banon later on. Now, you need to act fast. You can't just wait. You need to act fast and hit them hard. 10 to 14 days with an extra dose of the antibiotic, and hit them hard. Give it to them right after a patient complains with the symptom and you see a radiography with a cloudiness inside the sinus. If you don't, you might need to wait a longer period of time. So if you don't, you decide to wait. All right, I'll wait, I'll give antibiotic. Okay, I'll wait. Then you might have infection, really severe infection possibly, to travel a sinus to sinus. From maxillary sinus, you could even go to the ethmoid sinus, and this is 4 months after obstruction of the osteomedial complex. Now, it's not your problem anymore. You need to send it to an ear, nose, throat doctor, and they need to take care of a osteo to make that drainage occur one more time. So it is dangerous, it is dangerous, it is dangerous. These are immediate postoperative radiograph that I never want to see. It's almost like a volcanic eruption right there. You don't want to see that. You don't want to see all this a worm swimming around inside the sinus. You don't want to see that. Because these particulates, it gets traveled by the mucociliary reaction from the epithelium of the Schneiderian membrane to travel to the osteum, which is a medial wall, and it's 2.4 millimeter opening and functional. Now you might get stuck. Because if you're lucky, bone graft material comes out to the mouth, and patient feels the bone graft material in the morning many times. And if you're lucky, everything will come out. But if you're not lucky, then it gets stuck. So now, this is an osteo plugging associated with sinusitis. When it gets plugged, then you're going to be most likely to get an infection inside the sinus. Now, if you have an infection in osteum area, then if you have an obstruction in osteum area, then now you cannot really have any type of drainage. Therefore, you need to refer the patient to the ENT doctor, and make sure that a patient gets treated for a functional, a sinus endoscopic surgery, or a cold lung surgery. And my suggestion is functional endoscopic sinus surgery because it's minimal invasive, and you could place the implant later on as well with the grafting. Now, when you see a patient right here, the bone graft material is being stuck right into the medial wall. And it was stuck for more than 3 to 4 months. And there's no way, as a dentist or dental surgeon, to treat the soft tissue of the sinus, unfortunately. So, we give it to the ENT doctor to perform functional endoscopic sinus surgery. As you can see, it's being blocked, it's being obstructed. And now, it's almost like an IND, incision and drainage, and you open it up, and all this pressure is getting relieved, and all the exudates or pus is going to come out. And when you suction, you're getting suction, the bone graft material that's being stuck inside. There we go. So you can see a bone graft material. Now, what would you do a membrane has a perforation? Many people claim, or the studies claim that, many of the studies claim that a detectable perforation rate is around 4 to 6%. Detectable perforation means that, oh, I noticed the perforation in my case, so I'm going to report it. That's a detectable perforation. It's about 4 to 6%, but really, in reality, if you stick sinus cupping and actually see the study, it's no less than 13%. That means lots of perforation, even major, minor, lots of perforation is going on through the crestal approach. No less than 13%. What that means is that a majority of the transcrestal perforation is going undetected. So now, what do you do when you have a perforation? I feel that if you know how to do a lateral augmentation, lateral sinus augmentation, you could just change to a lateral sinus augmentation when you detect the perforation in crestal, And now you can isolate the perforation by separating a Schneiderian membrane and loosening the tension. And you can see a 360 degrees of a perforation. And this perforation can be fixed when you actually detect all the boundaries of the perforation. But microlaceration or a microperforation, which is less than 2 millimeters, according to many different studies, does not really affect the outcome of the crestal approach. Yes, I believe it's true, but in only healthy sinuses. Only healthy sinuses, which means preoperatively healthy sinuses, which means patient has to have a healthy sinus before you go in. So, no less than 13% means that you have a greater than 13% chance of having some type of problem when patient is not preoperatively healthy. So it will be a greater problem. So you must check the sinus health, and that's more important than what you could do as a surgeon. Now, there's also another study showing you that a perforation does not relate to an infection. Wow, really? This study is showing you that perforation does not really relate to the infection. But post-op chronic sinusitis appears to be limited to patient with a predisposition or a patient with a history of the sinus problem prior to surgery. Which means when patient already has some type of problem inside the sinus, then it could be more chance to have an infection when you cause any type of perforation. It's very hard to imagine, but this is true. You must check the patient's preoperative sinus health. But now, what if you just go in? What do? Is it the end of the world? No, it's not the end of the world. Luckily, Dr. Jung et al. In 2006 showing us that when you go up 2 millimeters, then you can see a Schneiderian membrane covering all the apex of the implant of the implant fixture. But when you go up 4 millimeters, then you can see that a Schneiderian membrane cannot reach all the way up there without a source. So you can see a rough surface being exposed, and this rough surface being exposed could be a seed for aspergillosis or other type of problem. But it's mainly asymptomatic, but it can be problematic. But we are scientists. We don't just go by this. We're scientists. And scientists talks with histology. So Dr. Zhang, at the year 2013, showed a 1 millimeter penetration and 2 millimeter penetration. As you can see, every apex is fully covered. But when you see a 3 millimeter penetration, starting there, you can start to see a partial coverage, which is showing us that 2 to 3, up to 3 millimeters or less is okay. 2 definitely okay. But starting a 4, you might have a problem. So knowing this, how can we utilize it in our clinical setting? Dr. Noah purposely went through, and 98.4% of the case will say no, that the 98.84% of the success rate was detected. Also, Dr. Aminajin says, you know what? For him, 83 implant with 70 patient, any perforation less than 3 millimeters, they will show, without graft material, will show no sinus complication and 100% survival rate. It doesn't mean that you could perforate purposely. You're going to try to lift it, of course, but if you do perforate up to 2 millimeters or less, then it's not really a big of a problem. If you have a more residual height to hold that implant for most of the BICs and of course the stability. So what would you do if you're placing a particular, what would you do if you have perforation? And now some people have an idea. They all have an idea. So you stick something, you stick a collagen tape and do it. Oh yeah, let's try this. You know what? It makes sense. It makes sense. Does it make sense? Doesn't make sense. Let's see. In small preparation, and it doesn't really affect clinical outcome in healthy science, we know that. But once you want to try to lift, you might want a prior elevation. That means you need to separate the sinus somehow before your preparation might be okay. Further elevation is no longer possible. If you start to place the bone graft material, what will happen then? Many times you'll go out, and you increase the size of the preparation. You think that it's going to be lifted. No. It's going to escape throughout the preparation, increasing the size of the preparation, which causes more risk to obstruct the ostium. Also, when graft can be displaced everywhere, and of course the mucociliary reaction of the Schneiderian membrane will carry all this particulate to the ostium, and maybe you'll be obstructed. Now, I'd like to talk about something called air fluid level and let you see. And I talked about this a little bit. This is above Schneiderian membrane, okay? Not underneath the Schneiderian membrane. Membrane is underneath, and whatever is top on the fluid on the top is called fluid level. And fluid level is like a moving cup. When you move the cup, water stays still due to the gravity and stay in shape when you move the cup. And that is called an air fluid level. So I want to mention this again. So preoperatively, you have a very clean, healthy sinuses with a radial lucency. But now in post-op, what happened? It's the same thing as what you saw before. You see a graft being a convex shape, which shows me that graft material is nicely contained. But you see there's a fluid above the Schneiderian membrane, which is a bleeding, constant bleeding, spontaneous bleeding, and escape through the A preparation and cause that type of thing. So what would you do? You instruct the patient, guess what? You might bleed through the nose when you sleep and when you wake up, and you must warn the patient that a patient might have a wetted, that's called a bleeding might come out. So what about the fate of that dental implant? I feel that in my case, when you see a convexity around the apex of the implant, usually, and I have a very, very good success because a graft material is at least being contained underneath the Schneiderian membrane. So what happens when bone graft material escapes beyond the Schneiderian membrane? What would you do? Pray very hard, pray it will come out the nose, pray it will come out the mouth. Maybe sometimes prayer works, sometimes prayer don't work. So let's see what works. What I like to do is to convert to the lateral. So I try to do a pressed approach, no problem. Okay, it should be very simple. But sometimes, I don't know what happened, and I'm making some mistake. Up to here, no problem. I see a bubble, so I feel very insecure. So I checked with the Valsalva, and it was Valsalva negative. So I started putting in the bone graft material and tried to suck the water out and found out that there's no pressure. When I try to suck the water out, if there's no pressure, that means there must be a perforation in the membrane. Then what do? I turn to a lateral, now it's a nightmare. And I think it's a nightmare. You need to really cleanse it out above the Schneiderian membrane and isolate the perforation and fix them through maybe a hard collagen membrane for a better space maintenance. And complete your sinus lifting process. So very simple process can be a very complicated result. Complicated procedure could be added. So now let's see some cases. When you see CBCT like that, what do you see? you see about a 2 millimeter to 3 millimeter of the residual bone. But what do you see above? You see an air bubble, air bubble, air bubble. Those air bubble could be a sign of the acute infection. So even before I touch the patient has some type of sinusitis, and that's usually acute sinusitis. So okay, so this needs to be treated. And in America, we don't want responsibility. We would like to give somebody else a responsibility, so we give to an ENT doctor. Now, why should you do a crestal approach when you have a very little residual alveolar bone height? In this case, there's two criteria that I like to address. Number one, the yellow line is longer than the red line. It's a depressed shape. In Kennedy class 3 situation, then you see in many of those with a very wide ridge. When you see a Kennedy class 1 and 2 type of situation with the distal extension, then you can see the yellow line is shorter than the red line. When yellow line is shorter than the red line, then you have a higher chance of the perforation many times. The membrane is going to get extreme tension. So this is definitely favorable. This is class 3 and also a depressed shape. Nice. So we decided to do a crestal approach in a 2.9 millimeter, around 3 millimeter of the case. But it's very, very predictable if you see a shape and if you see a Kennedy class 3 type of situation. So no problem. Really no problem. So I think that it's not just the residual alveolar bone height, it's the shape of the sinus, and you can see how much are you lifting and how much tension is being applied in the apex of the Schneiderian membrane. So crestal sinus graft can be possible with a less than 4 millimeter of the alveolar ridge. 6 months post-op, and new sinus flow formation is seen starting right there. You can see it. Okay? Now, I'd like to introduce you to one more patient. This patient has a much fear to the dentist. So scared, so scared, so scared. So we decided to try to do a minimal invasive approach. It's a very apprehensive patient. We decided to place a full dental implant. So this was the plan, and as you can see, and first molar has a very little residual bone height with wide sinuses. Okay, this should not be so much of the problem, but things can go wrong many times. Things can get unpredictable during the surgery. So did a surgery, no problem. First 2 was inserted without a problem, but starting the third one, I felt that there was a membrane perforation. So how did I check for membrane perforation? Before, there was no perforation. After, I have small perforation because I'm going to suck that water down, suck all the fluid down, and when membrane is nicely intact, you'll get right suction right back. But when you suck that fluid down and it just loses with the bubble, then a Schneiderian membrane has some type of perforation. So I detected perforation, and that time I did not want to place the bone graft in a number 6 and 7. So what we did was to skip the A6 and go to 7 without a grafting. And of course a GBR was done as well. Now by suctioning the fluid, I really like it. I really love doing this because it will give me a sense that do I have a perforation after graft material? And also, I know that I can localize the graft material as well as to decrease the dead space. And decreasing the space, like many people say, all the fluid gets reabsorbed inside the sinus. Yes, it will, but what I see in my case is that sometimes a sinus membrane remains thick for many times. And this a thick blood filament is thickening those membranes. Right after I kind of taking all this fluid out, I feel that patient gets much more comfortable after surgery without much complication. So this is a must-have for me these days, and I like this process. So rebound of the syringe is need to be detected. When you use the 3 cc syringe, very tiny syringe, and when you pull and it rebounds, then I know that membrane is intact. When you just cut out with the bubble, then there was some type of damage inside the membrane. Now, skip the due to low residual alveolar bone and perforation, but we decide to place a dental implant without a graft material and a number 7 site. This is immediate post-op. And 1 month, I was a little bit scared, so I wanted to check for sinus infection, even though patient did not have any symptoms. And now 1 month post-op showed me, and there was no sinus infection. Good. 5 months post-op, and you can see that graft material is staying very nicely. 2 years and 1 month post-op, you can start to see all this new sinus formation. 5-year post-op, it's no longer pneumatizing, it's being stuck by the apex of dental implant. And 7 years post-op, and you can see a very, very stable 4-unit bridge on the right side of the patient's maxilla using a sinus lifting technique and as well as a no sinus bone grafting technique in number 7. So, when to use no bone graft? I like to use bone graft many times, but no bone graft can be very beneficial in case of a perforation and in case of some situation. Everybody gets into a certain situation, but I still prefer to do a with bone graft to resist the bone mesial stress and give a maximum bone-to-implant contact. So, I'm going to present you with additional prevention strategies. And this is really the most important thing. Check with the correct radiography. Okay? If you look at 2-dimensional picture, you can see an 8.12 millimeter, and it seems fantastic. You could place a 7 millimeter implant. But is it for real? When you see this, and this is 4 millimeter when you look at CBCT, or even maybe less when you go up. So, you must check with 3-dimensional x-ray for a sinus health, and of course the anatomy of the hard tissue. Also, if you make an extraction, many of the HeLa or infection has a very, very thin bone, under bone, going right up into the sinus. If you just leave it, it will really go into under a rapid changes, so that it will sink down. Now you might need to do a more complex surgery. So, alveolar socket preservation to increase the vertical dimension is a very useful method in a posterior maxilla to minimize the surgery. As you can see, a simple implantation with a crystal, a floor elevation, with a comparing to lateral window sinus graft, and you can see much less invasive a procedure could be done after a alveolar socket preservation. I'd like to also introduce you to a digital guided surgery. Digital guided surgery can be magical. Now, first of all, posterior maxilla has the maximum amount of the keratinized gingiva, in my personal opinion, in all the oral cavity, and wide ridges. So, it's one of the areas that you could really punch without risking the neck of the keratinized gingiva on the buccal side. And of course, by doing the digital, and you could imagine the final prosthesis and where the access channel is going to be after the sinus surgery. And also, I'm a right-handed. I don't like doing a left side, quadrant 2. I don't like doing this too much. I don't like this doing too much. So, I like to use the guide surgery to make sure that I get very, very comfortable in my 3D positioning of dental implant, and also I can concentrate more on sinus lifting. One thing that's a great thing about this kind of surgery is that with a free hand, you really don't know where you're going. You think it's 5 millimeter, but it could be a 6 millimeter, 7 millimeter, 8 millimeter, depends on where you go. But this guide surgery allows you to go in where you want to go. So, and you'll know that you could remove the bone completely. You could remove the bone completely into the osteotomy, so that you could insert the graft material without any resistance. If those of you who's doing a sinus surgery, by the way, those of you who's doing a sinus surgery, did you ever had a problem? You tried to engraft the bone, and both your Schneiderian membrane is resisting your force. And you get scared, and you ended up just going to place an implant many times. But let me tell you, Schneiderian membrane cannot resist your force. Cannot. What's really happening is the incomplete osteotomy and graft materials being stuck at the floor of the sinus, and it does not allow you to advance. So it's very, very important to make a full access into the sinus to get a better dome shape as well as for a comfortable grafting. And if you graft like this, of course, if you use the guide to the sinus, of course, ideal three-dimensional position is given, and ideal a prosthesis will come out, as well as a new sinus formation with the most predictable way to lift the sinus, in my personal opinion. Now, you can see a day of the surgery, and new sinus formation after 1 and 5 months later. And of course, the restoration is the center, the access is the center of the restoration to make sure that you're a center of the restorative crown. Now, you could gain the primary stability and by using a similar design, taking advantage of the similar design that picture has. So, TS4, ET4 is a very, very narrow shape, and I love that shape. I love that shape. That's in a fashion in year 2024. Because it will give you that a maximum initial stability with a wide pitch, especially a low density bone, such as posterior maxilla. You can make a very, very small access into the sinus and stick that in to gain that initial stability. I love that a taper implant. Also, ultra-wide implant. So therefore, I want to tell you and show you, because there is a huge comparison between, can I just use short implant? Do I need to go to sinus? Can I use an angled implant? What would you do? What would you do? So I'd like to introduce you to a rational short implant. When you see a sinus lifting, I already told you that in crestal sinus lifting, the narrow sinus actually benefits. But a sinus width is determined at the apex of the implant fixture. So as you look at this case, between narrow sinus, regular sinus, and wide sinus according to this journal, and showing you that when you go in less, then you're really having a narrow sinus all over to increase the predictability of the crestal approach. So, wow, this is nice. Narrow sinus can maximize the bone implant contact along the lateral walls. But what about the crown and implant ratio, Dr. Chang? Is there a crown and implant ratio? Is there a crown and implant ratio? Really? Really? It's only a long clinical crown, a short clinical crown that matters. Long clinical crown is of course more risky, but a short clinical crown is less risky, that's all. Regardless of the implant length. Because the implant does not have a PDL. It's not a one structure. The joint is there. And it starts from the joint. So, many journal states that, and this is the most recent journal that I have, that an increased crown implant ratio does not directly relate with increased marginal bone loss and does not represent the biomechanical risk. So, why not? Olsten has made a short implant ever since the year 2011. What are the indications? Well, the patient is chronic sinus. And of course, higher a periarticular nerve or lower a articular bone. So all this implant, short implant that I feel is a non-grafting solution. You might need to avoid a grafting. And Olsten came up with the 1485 kit and 485 kit to make sure that you could place the short implant into an ideal three-dimensional position. Now, does short implant work in long term? Well, take a look, year 2012 to 2022, I think that crestal bone loss is not there. Not there. Wide implant. Very, very nice. Long-term data, no problem. So, when patient has a problem with sinus, short implant could be used. And this is a viable option to do so. And there are many short implant usage and recorded in long term. Now, this is my mentor, another mentor, Dr. Yong-Suk Cho, that I'm going to show you. But now, he believed in short implant so much that he placed short implant himself. Look at that mirror. I thought that was amazing, but he should not do that. I don't recommend anyone to do that. But he did it, and he proved that in 5 years, 5 months, 7 years, and 9 months. And this gentleman happens to be a Yong-Suk Cho. Now, this is how I think. Short implant versus sinus grafting. You can't really compare, because it depends on the situation and depends on the predictability. You're going to choose either procedure. So you're comparing different food. But I really feel that this could be combined into a wonderful weapon, wonderful arsenal that you have. And some cases you will approach a short implant, some cases that you will approach with a sinus lifting to make sure that you increase your predictability on your clinical cases. So, take-home message here is that prevention is the best way. A solid diagnosis and proper treatment planning with detailed pre-operative assessment. And you need to take it easy. Take a baby step. Use 1 implant first, then 2 implant, and 3 implant with sinus lifting. And later on, you can conquer a bigger and bigger cases. Follow the basic principle and apply surgical technique, and improve your surgical skill through hard and tough training. Adequate management of the complication immediately to get the recovery, and build the good rapport with the patient, which I feel that is one of the most important. Some patient will forgive you. Some patient will never forgive you. So make sure you communicate well with the patient and build a wonderful rapport with the patient. And I thank you so much.
Thank you so much for the presentation about management of complication in crestal process lifting. So from now on, let's have a Q&A session. If you have any question, just raise your hand. We will give a mic.
Trong hội trường có bác sĩ nào có câu hỏi không ạ? Thì bác sĩ có thể giơ tay để ban tổ chức đưa mic tới ạ.
There is no question. I want to ask something about the bone graft material for crestal approach sinus lifting. So, how do you think about appropriate kind of graft material for crestal approach sinus lifting? And then, how much should we pay?
For crystal sinus lifting, the question was, what kind of bone graft material would you use in crest sinus lifting, and how much a bone graft should be utilized for a crest sinus lifting? There are many options for bone graft material, and I feel that there are no best bone graft material, but to use a bone graft material, characteristic of the bone graft material is maximum extent. An allograft is going to, allograft and autogenous graft is called resorbable graft material to completely turn into patient's own bone to make sure that you get a floor of the ceiling right above the floor of the sinus. And now, that's the huge advantage, but it resorbs quite a lot. You lose the space quite a lot. There's a xenograft particle. You can almost guarantee that you will retain the volume very, very well because it's reparative material. Because all this xenograft particle is encapsulated by the new bone, like this. and you would definitely give me the volume. Which one should I use? If I am doing a simultaneous implant placement, which means that if I'm placing implant with the graft together, I like to use an allograft. Why? Because it will come down, yes, it will come down, yes, it will come down, yes. When it hits the apex of the sinus, it doesn't come down too much anymore. So I like a regenerative property of the allograft, and I like to use that. But if I'm doing a stage approach, if some people referred me to do any type of sinus, a grafting staged, usually it occurs in lateral sinus, stage, then I'm going to graft with some type of xenogenic mix. Xenogenic bone and maybe an allogenic bone a little bit to have a volume occupied so that a dentist who refers me could maybe use the guide or and free hand to place an implant and maybe 5 to 6 months later without any complication. How much bone graft do I need to use? Well, it's not really how much do you separate. So I need to use exactly how much I separate. It's very two-dimensional thinking, and you're much smarter than that. You need to know what kind of fixture am I using, length of the fixture. What length of the fixture? Am I using 10 millimeter? Okay, if I'm using 10 millimeter, and I have 6 millimeter of the bone, then I need to raise 4 millimeter of the bone minimum, 4 to 5 millimeter. According to the research, when you want to raise 3 millimeter of the sinus, there's 0.36 millimeter, 0.36 cc of the graft. And if you want to raise a 4 millimeter, you could add 0.5 cc of the graft material. And if you want to raise 5 millimeter, you could add 0.7 cc of the graft material. If you want to raise 6 millimeter, you could add a 0.9 cc of the graft material, according to Dr. Lee and Day. So that's what I go by, but there are many different researchers out there, such as Dr. Kranemar's research in 2013, I believe. I have to check again. But you can kind of see, compare the average sinus volume and how much you could lift up and formulate your graft material, amount of the graft material to be inserted inside the sinus. And now, however, I feel that putting on some amount of the graft material or not amount of the graft material is not as significant as separate the membrane widely, and then without a membrane perforation, you insert your implant. Any graft material that occupies a space, according to research, including alloplast, autogenous bone, xenogenic bone, and a allograft, they all work fine inside the sinus. I think that's one of the wonderful characteristics of having a whole wall with a wonderful blood supply. And that's what I think. Any other questions?
Ban tổ chức có phiên dịch nên là quý vị có thể hỏi bằng tiếng Việt và sẽ có phiên dịch sang cho bác sĩ Trong ạ.
Vâng, phép cho em có 2 câu hỏi. Câu thứ nhất là một số bác sĩ hiện tại là cái chiều dài xương còn lại khi nó sống kính là một số bác sĩ 2 đến 3 mm người ta vẫn nó sống kính, thậm chí 1 mm người ta vẫn nó sống kính nếu như vẫn đạt độ đỉnh sơ khởi khi họ xác định từ đầu. Ví dụ như xương D1 ở xương vỏ thì quan điểm của bác sĩ thế nào? Và thứ hai là nếu như cái vị trí mình ví dụ như một răng thôi, nhưng mà vị trí mình cần nâng xương kính và có cái vách thì bác sĩ sẽ xử lý thế nào để mình nâng nó an toàn?
Okay, we have 2 questions. The first question is, what is your opinions? Because in some dentists, some famous dentists, they recommend even in case we have like 2 to 3 millimeters of residual bone height, or even 1 millimeters. If we can achieve primary stability, we can still place implant. So what is your opinion about this statement?
In crystal approach?
Yes, crestal approach.
Okay. There's many people who thinks that way, and I think it really depends on the situation. I just showed you, if it's Kennedy class A3 type of situation when you have a Y sinus, and also the Y sinus but Y bridge, and also have a shape in depressed, yes, you might be possible, no problem. But I would never teach anyone that. Why? Because that person might not have done maybe 100 or 1,000 sinus lift. When you tell me you never break the root before in extraction, then I feel that you haven't done enough extraction. When you do enough sinus, then the statistic almost becomes very similar. And when you have a bone and less residual alveolar ridge, it becomes very, very risky in many different ways. Can you do it? Can he does it? Can you do it? Can I do it? Yes, we can. But if we do it 1,000 times, versus when we have a 5 millimeter of the bone and when you do it 1,000 times, which one would you have a better predictability? Also, when you do 1,000 times lateral approach, and then place a implant 1 millimeter, 2 millimeter, no problem. Can you get good biological width? Can you get 1 millimeter bone on the top? So I feel that all the situation explain should we do it or should we not do it? I feel that it's more predictable to do a crestal approach when you have a more than 4 millimeter, but in certain cases, I feel that it is okay to do when you meet these type of criteria that I showed you during my lecture. And I feel that a teacher should never teach that way.
Thì câu trả lời của bác sĩ Trong đó là theo tôi ấy, thì cái vấn đề ở đây là không phải là cái điều đó, tức là trong cái trường hợp mà xương 20m, 30m hay là thậm chí là 1mm đó là chúng ta có thể làm được hay không. Có thể ở đây rất là nhiều người chúng ta có thể đặt những cái implant nếu mà đủ đi sơ khởi chúng ta có thể làm được cái điều đó. Tuy nhiên thì nếu mà chúng ta đặt cái implant đủ nhiều, tức là khi mà chúng ta cái số lượng implant chúng ta đặt càng lớn thì cái con số thống kê, cái quan trọng ở đây là cái sự tiên lượng được cái kết quả thống kê ra được, thì chúng ta sẽ thấy là sẽ gặp nhiều những cái biến chứng hơn, đúng không? Tức là nếu mà chúng ta tuân thủ những cái mà thầy đã recommend, tức là đã đề xuất ở trong cái bài báo cáo vừa rồi, thì chúng ta sẽ thấy là kể cả chúng ta có nâng hàng nghìn cái ca lâm sàng sang nữa thì cái tỷ lệ thành công chúng ta sẽ vẫn rất là cao. Nhưng mà nếu mà chúng ta không tuân thủ cái điều đó thì có thể chúng ta sẽ thành công trong một vài cái ca, nhưng mà nếu mà chúng ta càng làm nhiều chúng ta thấy là cái tỷ lệ thất bại sẽ càng cao. Đó. Và trong những cái thầy cũng có chia sẻ rằng là nếu mà là bản thân thầy, nếu mà thầy là cái người mà dạy cho những cái bác sĩ khác ấy, thì chúng ta không nên dạy những cái điều này, tức là chúng ta nên gắn với những cái tiêu chuẩn nhất định để chúng ta đảm bảo cái an toàn, và quan trọng nhất là cái khả năng tiên lượng được, cái sự tiên lượng được khi chúng ta làm, thì đó là cái điều quan trọng nhất.
Also, you might work on that person's hand. That person might be a really, really wonderful surgeon, but like I said, not everybody has an equal agility or equal experience. So I feel that when you teach, we teach what is predictable. We don't just do one cases, but we do thousands, hundreds, thousands of cases. And how can I get best predictability? And I feel that that is the way to approach every one of our cases. And that's how I feel.
Thì thầy cũng nhấn mạnh lại đó là cái việc mà chúng ta làm được hay không thì nó có thể là sẽ phụ thuộc vào kỹ năng của từng bác sĩ nữa. Nếu mà chúng ta có đủ kỹ năng thì chúng ta hoàn toàn có thể tự tin chúng ta làm những cái chỉ định đó. Nhưng mà nếu mà bởi vì là thầy là cái người mà đi giảng rất là nhiều, và khi chúng ta giảng cho các bác sĩ khác thì chúng ta sẽ đặt cái vấn đề là về cái tiên lượng, đúng không? Chúng ta sẽ phải có những cái tiêu chuẩn nhất định để chúng ta làm sao mà các bác sĩ mà đều theo cái tiêu chuẩn đó thì họ đều đạt được những cái thành công trong điều trị. Và quan trọng nhất là cái sự tiên lượng được trong điều trị. Đó là cái yếu tố quan trọng nhất.
When you do a lateral approach, it's a little bit different story. When you have a very little residual bone height, but it's not just the implant placement what you could do. It's really how predictably can you treat your patient, and I think I should.
Kể cả trước khi chúng ta có nâng xoang kín, nâng xoang hở chăng nữa, thì cái việc mà chúng ta có đặt cái implant tức thì hay không thì nó cũng là nó lại là một câu chuyện khác, đúng không? Nhưng mà cái quan trọng là cái như thầy đã nhấn mạnh là cái việc mà chúng ta có tiên lượng cái tiên lượng điều trị hay không, nên là chúng ta nên bám sát theo những cái mà người ta đã có y văn, người ta thống kê và những cái đề xuất ở trong y văn và theo những cái tiêu chuẩn mà đã được đưa ra trong cái bài giảng. So the second question is in case we have we need to do the sinus lift in area 1, 2, 3, 6, and we have the septum there. So how can we overcome this situation?
Well, septum is actually negative, much negative effect, many times a lateral window. But septum is not all negative, not always negative. Septum could provide additional bony surface. Septum could partition the area to literally make it a narrow sinuses. And septum could also give a good initial stability many times towards the apex. But if you use a certain method, just say densaver, if you do osteodensification, and there are contraindications to septum. But in some of the cases, such as hydraulic pressure, I feel that that's one of the advantage of using hydraulic pressure. When you use the hydraulic pressure, you could easily separate the septum because you're applying all the equal pressure to all the molecule according to Pascal's principle. So septum, I feel that PEST approach can be very advantageous.
Thì câu trả lời của thầy đó là trong những cái trường hợp mà chúng ta có cái vách xoang ở vị trí mất răng, ở vị trí mất một răng thì nó lại thậm chí nó là một cái thuận lợi của cái kỹ thuật nâng sang thủy lực. Tại vì như trong cái ví dụ trong cái bài giảng của thầy thì ở cái vị trí cái hàm lợn, mặc dù cái xoang nó dày, cái vách xoang nó dày đặc như vậy, ta vẫn có thể nâng cái màng xoang lên dù vướng cái vách xoang. Và cái vách xoang thì thậm chí là ở cái vị trí mất một răng đó thì nó sẽ có những cái thuận lợi là gì? Nó có thể tăng cơ lực sơ khởi, nó làm cho cái xoang của chúng ta trở thành một cái xoang hẹp, tức là chúng ta có nhiều cái nguồn cấp máu từ trong xương ra cái xung quanh implant hơn, tăng ổn định sơ khởi của implant hơn, tăng cái tỷ lệ tiếp xúc xương với implant. Do đó thì những cái trường hợp đó thì thầy nghĩ là nếu mà những cái chỉ định như là có những cái chỉ định của cái densaver, cái mũi densaver thì họ thậm chí họ cũng có thể là họ khoan vào cái xoang nó được, nhưng mà với vào cái vách xoang nó được. Nếu mà chúng ta sử dụng cái thủy lực ấy, thì chúng ta hoàn toàn có thể tách cái màng xoang ra khỏi cái vách xoang rất là an toàn, và sau đó thì chúng ta khoan như bình thường thôi.
No more questions. So if you guys don't have a question anymore, so it's time to close the session 3. Thank you for wonderful presentation, and let's give a big applause.